Hey everyone, welcome back to my channel. I'm Sheila G, the PAC, and today's video is going to be on my top 5 skin-related emergencies that you should know about. Now, this list does not include things like spider bites or third-degree burns, which are pretty obvious skin-related emergencies that we tend to think about immediately when considering emergencies in dermatology. But instead, this is a list of conditions that may start off as seemingly harmless, but are in fact true emergencies that can lead to very severe or even life-threatening complications if not treated promptly. Before we get into those though, of course, don't forget to like, comment, and subscribe to my channel for all things dermatology. Let's get right in.
I want to be dermatologist. Dermatologists apply lotion for a living.
Actually, listen, we don't just apply lotion all day, every day.
No. Well,
in all seriousness, dermatology offices are very busy. We see a lot of patients, and for the most part, what we see is generally low risk. However, you never know when something serious is going to walk through that door, and we have to be able to recognize when something is already an emergency or a potential emergency. And that brings us to our first and one of the most serious dermatological emergencies, known as Stevens-Johnson syndrome / toxic epidermal necrolysis. Now, these are actually two separate conditions, but kind of grouped together, and I'll explain the difference momentarily. But essentially, Stevens-Johnson syndrome is a severe skin reaction where the skin and the mucosa detach and form blisters on the skin, and that's usually due to a medication. Now, the mucosa is a type of tissue that lines different cavities of the body, so inside the mouth, the nose, the GI tract, for example. And this happens when the body cannot detoxify the metabolites from different medications, and so the immune system actually goes in and attacks the skin and the mucosa and separates them, and then it causes cellular death, and we call that apoptosis. Now, when less than 10% of the body surface area is affected, we call that Stevens-Johnson syndrome. When over 30% of the body surface area is affected, we call that toxic epidermal necrolysis, or TENS. Now, if it's between 10 and 30%, we kind of just combine the two names together. As far as the most common offending medications that are involved in the development of these conditions, we typically see certain antibiotics, such as Bactrim, which is a sulfa-based antibiotic, allopurinol, which is a medication that treats gout, and then certain anticonvulsant medications, which are medications that treat and prevent seizures. The condition usually presents 1 to 3 weeks after starting that medication, but it can take up to 8 weeks for that to develop. Now, in more severe cases, we may see what's called prodromal symptoms, which are symptoms that happen before the rash starts. And those include fever, fatigue, joint and muscle aching, and upper respiratory symptoms. Now, in early Stevens-Johnson syndrome, we start to see kind of these purplish macules or patches either on the skin or the mucous membranes, and they can start to spread from the hands and the feet to the arms, the legs, and the face. And over time, they start to create these very painful blisters, and the skin itself may start to just slough off. So remember that this condition can affect the mucosa, so it can affect the eyes, the esophagus, the GI tract, the genital mucosa, and even other organ systems. And if not treated promptly, it can lead to blindness, severe scarring, dehydration, organ failure, and even death. Now, these patients need immediate transfer to the ICU or the burn unit with aggressive supportive care, and the offending medication has to immediately be stopped. One of the most important things as far as treatment is providing fluids to the patient, pain management, and also monitoring for any secondary infections, which those can lead to a lot of other complications and even death. The overall treatment is a little bit complicated, but those are the most important things. The next emergency is herpes zoster ophthalmicus. Now, you may have heard of shingles before, which is essentially a viral infection caused by herpes zoster virus. Now, herpes zoster is essentially the reactivation of varicella zoster, which is the same virus that causes chickenpox. So as a kid, if you have gotten chickenpox, basically that virus lays dormant in the nerve cells sitting just outside of the spinal cord. And later on in life, that virus can reactivate and follow a nerve path, and we call that shingles or herpes zoster. Now, because this virus is following a nerve path, we typically see it affect one side of the body, usually in a linear distribution. So it presents as a pretty painful rash with little clusters of blisters. And the patients normally describe the pain as kind of a burning sensation. Sometimes even before the rash outbreaks, we can feel that burning and that tingling in that linear distribution. And again, that's called a prodromal symptom. Now, anytime we even suspect shingles, we like to treat the patient with a high-dose antiviral medication, either valcyclovir, which is Valtrex, or acyclovir for several days. Now, you might be thinking, what's the emergency? Well, herpes zoster becomes an emergency when it affects the ophthalmic branch of the trigeminal nerve. The trigeminal nerve is a major cranial nerve that has 3 branches which control some motor function and sensation of the face. So the ophthalmic branch actually supplies sensation to the eyes, the nose, and the forehead. And when herpes zoster affects that nerve in particular, it can cause some serious problems. So when herpes zoster does affect that branch, we call that herpes zoster ophthalmicus, and it can lead to a lot of inflammation and pain on or around the eyes, which later on can cause visual abnormalities or even blindness, because it can cause corneal ulcers or even glaucoma, which is from high pressure within the eye from inflammation. Now, if the patient does have herpes zoster affecting this nerve, but there's no visual abnormalities or the patient does not have pain on or around the eye, we don't necessarily send to the emergency room. But of course, we treat them with high-dose antiviral medication as well as corticosteroids. But in the event that these things are happening and we do send to the emergency room, it's very important that they get a proper examination of the cornea and the conjunctiva, looking for specifically corneal ulcers that can be caused by this virus. And the retina needs to be examined too, because when that's involved, that can cause some visual abnormalities. In some cases that are more severe, the patient may require IV antiviral medications and a referral to an ophthalmologist. The next emergency is angioedema, which is when deeper tissues, so the subcutaneous fat or the mucosa, become extremely swollen. Now, angioedema is considered a type of urticaria, which urticaria is an inflammatory reaction on the skin that's driven by histamine release in the skin. And when there's histamine and fluid that's released into these tissues, we can see hives or wheals on the skin. And those are those really itchy flesh color bumps that come up temporarily and then they start to go away, usually due to some sort of allergic reaction. However, when deeper tissues are involved, again, the subcutaneous fat or mucosa, it can cause a lot more problems. So angioedema, again, is swelling of those deeper tissues, deeper than the skin itself. And that usually presents on the face, the lips, the tongue, and sometimes it can affect the throat and become an emergency. Angioedema can happen either on its own or along with the presence of hives on the skin. And normally angioedema in a lot of cases is caused by either a medication, a food allergy, or there is a hereditary form of angioedema. Now, one of the most common medications that lead to angioedema include ACE inhibitors, which are actually, that's a type of blood pressure medication. It's a class of blood pressure medications. And so we can see swelling of the lips, the tongue, and when it starts to affect those airways, and it can happen quite rapidly, it becomes a life-threatening emergency because then the patient can't breathe properly. If the airways do become compromised, the patient needs immediate administration of epinephrine, and that's usually in the form of an EpiPen. Now, if the patient does not respond to epinephrine, sometimes they may require intubation or even a tracheotomy. Now, in milder cases where the airways are not affected, angioedema can be treated with antihistamines and sometimes steroids. The next emergency is cellulitis, which, simply put, is a bacterial infection of the skin that results from Staphylococcus or Streptococcus bacteria. And it often starts from some sort of cut or injury on the skin. And cellulitis presents as really red, swollen, and painful skin, and there may or may not be the presence of a fever. So the problem with cellulitis is it can spread rapidly into the deeper tissues and even into the bloodstream, where it may cause sepsis, and that can be a life-threatening situation. Now, depending on the severity and the presence or absence of fever, chills, and other symptoms, the patient may either be sent home with oral antibiotics, or they might require a trip to the emergency room. Now, if a patient is not experiencing a fever, chills, anything like that, and we send them home with oral antibiotics, we often draw a line on their the affected area. So for example, the leg. We often draw a line where that redness stops, and we always tell the patient to immediately go to the emergency room if that redness spreads beyond that line and or they develop fever, chills, or any other symptoms. And in those cases, they may require IV antibiotics and a complete workup for potential sepsis and other complications. Now, last but certainly not least is a very serious condition known as eczema herpeticum. Now, this is essentially where eczema has now been complicated by a viral infection, specifically herpes simplex virus, either 1 or 2. And this presents as very painful clusters of blisters and ulcers that can start to kind of crust up, and it can cause some serious complications like fever and other systemic symptoms. And when that skin has already been compromised from the eczema, it's a lot more prone to developing that sort of infection. So those who have eczema already, so atopic dermatitis, which is the most common form of eczema, they can be at higher risk. So because that virus is affecting the compromised skin, it can become pretty widespread, and it can even start to spread to other areas such as the genital region and the eyes, and that can cause its own complications. And those who have a compromised immune system or a weakened immune system, it can spread to the bloodstream and potentially other organs, which is a huge problem. Now, depending on the extent and again the severity, we may or may not send the patient to the emergency room, but of course, if any of those complications are identified, we have to send. In the emergency room, the patient's usually treated with antiviral medications, such as IV antivirals, and are given supportive care and further testing. So there you have it, my top 5 skin emergencies. I really hope you found this video helpful and informative, and thank you guys so much for watching. And as always, please don't forget to like, comment, and subscribe to my channel for all things dermatology. I'll see you next time.